Hi all, welcome back to my channel. I hope you guys are doing good. Again, I am back with an interesting topic, atrial fibrillation, commonly known as AFib. It is the common type of cardiac arrhythmia. It occurs when the heart's upper chambers, called the atria, beat irregularly and rapidly instead of maintaining a normal rhythm. In this presentation, we will discuss the causes, symptoms, complication, diagnosis, and management of atrial fibrillation. Let's move on to the topic. Before diving to the topic, let's discuss about some relevant things. The normal cardiac conduction. The heartbeat begins in the SA node, which is the heart's natural pacemaker. The electrical impulse spread through the atria, causing them to contract and push blood into the ventricles. The impulse then reaches the AV node, where it is briefly delayed to allow the ventricles to fill. It then travels through the bundle of His bundle branches right and left and Purkinje fibers, causing the ventricles to contract and pump blood to the lungs and the rest of the body. As I explained in the previous slide, the heartbeat begins in the SA node, then to the AV node, then from there to bundle of His bundle branches right and left and Purkinje fibers, which cause the heart to contract and relax normally. In atrial fibrillation, the normal electrical conduction becomes chaotic and irregular. Multiple abnormal electrical impulses in the atria cause them to cure instead of contracting normally. It leads to irregular AV node conduction, results in irregular ventricular heartbeat. Now you got a clear idea about the normal conduction system of the heart and what happens in atrial fibrillation. It is an irregular and often rapid heart rhythm caused by abnormal electrical signals in the atria, making them cure instead of contracting normally. It is a supraventricular arrhythmia because the abnormal electrical activity originates above the ventricles, mainly in the atria. So the atrial rate reaches 300 to 600 beats per minute, overwhelming the AV node and causing an irregular ventricular response. Atrial fibrillation causes reduced cardiac output because the atria do not contract effectively and the ventricular rhythm becomes irregular. Let's talk about some of the risk factors and triggers of atrial fibrillation. Major risk factors are increasing age, hypertension, coronary artery disease, previous heart attack, heart failure, heart valve disease, diabetes mellitus, obesity, sleep apnea, hyperthyroidism, chronic kidney disease, and previous AF or other heart rhythm disorders. And common triggers are alcohol consumption, excessive caffeine, stress and strong emotions, lack of sleep, dehydration, fever or any acute illness, intense exercise, and stimulant drugs or medications. Most common symptoms of atrial fibrillation: irregular heartbeat, chest pain, extreme fatigue, shortness of breath, dizziness or lightheadedness, fainting, and palpitation. Let's talk about the types of atrial fibrillation. It is classified mainly based on how long it lasts and whether it stops on its own. If the symptoms are self-limiting, that is, starts and stops on its own and lasts for less than 7 days, we call it as paroxysmal atrial fibrillation. If it is sustained lasts for more than 7 days and needs medical intervention to stop, we call it as persistent atrial fibrillation. If continuous AF lasting for more than 1 year, we call it as long-standing persistent atrial fibrillation. Here, the heart structure may be dilated or scarred. The last one is permanent atrial fibrillation. Here, AFib is accepted as permanent. No further attempt is made to restore normal rhythm. Decision for long-term rate control and anticoagulation. How to diagnose atrial fibrillation? ECG is the main diagnostic test for atrial fibrillation. ECG hallmark of atrial fibrillation is irregularly irregular RR intervals, as you can see in the ECG, absent P waves, you cannot see P waves, fibrillatory waves seen as small chaotic undulations, and variable ventricular rate. As I said, ECG is the main diagnostic test for atrial fibrillation. But if the symptoms are intermittent, for instance, in case of paroxysmal atrial fibrillation, we can place the patient on Holter monitor, patch monitor, or event monitor, which continuously records the ECG, often 24 to 48 hours or more than that. Implantable loop recorder also considered in selected patients. We have to look for the cause and associated heart problems. So echocardiogram will be done to evaluate the cardiac structures and function. Basic blood tests such as electrolytes, renal function, thyroid function, complete blood count, and others are clinically indicated. Assessment for hypertension, heart failure, coronary disease, valvular disease, sleep apnea, and other cardiovascular risk factors. Let's discuss about nursing assessment. History collection is the first step. Always ask for symptoms such as palpitation, breathlessness, dizziness, chest pain. Onset and duration. When it started, how long episodes last, and its frequency. Any triggering factors such as exercise, alcohol, caffeine, stress, or illness. Past history of hypertension, heart disease, diabetes, thyroid problems, sleep apnea. Are they on any medications such as antiarrhythmics, anticoagulants, and other regular medications? Any previous AFib treatment like cardioversion or ablation? Any previous history of stroke or transient ischemic attack and bleeding problems? And also family history of AFib or other heart conditions. The second step is physical examination. So check the vitals, check the pulse and heart rhythm. Always check both radial pulse and apical pulse. Radial pulse may be irregular and weaker because some heartbeats do not produce a strong peripheral pulse. Apical pulse gives the true ventricular heart rate. Pulse deficit can also be noted in AFib, that is the difference between the apical and radial pulse. Blood pressure, assess for hypertension or hypotension. Always listen for irregular heart sounds and murmurs. Check for signs of heart failure, signs of thyroid disease, and neurological status if indicated. The third step is diagnostic test. So as you all know, ECG is the main diagnostic test for atrial fibrillation. You can notice absent P waves and irregularly irregular rhythm. Cardiac monitoring, blood test, and echocardiogram as indicated. The fourth one is risk assessment. Assess stroke risk, bleeding risk, heart failure, and factors that may trigger atrial fibrillation. The last one is preventing complications. Monitor for stroke, heart failure, and poor cardiac output, give prescribed medications, monitor anticoagulations and bleeding risk, and also provide patient education. So far, we have discussed about the normal conduction of heart, what happens in atrial fibrillation, risk factors and triggers, symptoms of atrial fibrillation, types, how to diagnose, and nursing assessment, where we have seen always to assess the patient for stroke. In this slide, we are going to see how clot form in atrial fibrillation and end up with stroke if not treated with appropriate anticoagulants. In the first picture, if the heart rhythm is normal, the atria contract effectively and blood flows smoothly into the ventricles. In case of atrial fibrillation, the atria cure just fibrillate instead of contracting effectively. The ineffective contraction causes blood to pool and become stagnant in the left atrial appendage, as you can clearly see in this picture. The stagnant blood can lead to clot formation in the left atrial appendage. The clot can dislodge from the left atrial appendage and travel through the bloodstream. So, if the clot travels to the brain, it can block an artery in the brain, causing an ischemic stroke. In case if it is traveling to other organs, it can also be affected, end up with ischemia. Now you got a clear idea about the main complication of untreated AF. Let's discuss about the other complications too. So the first thing is stroke or transient ischemic attack, as we have discussed in the previous slide. So blood clots can form in the atria and travel to the brain. If it travels to other organs, it can end up with ischemia, that is thromboembolism. Heart failure, persistent, rapid or irregular rhythm can weaken the heart. Reduced cardiac output. Ineffective atrial contractions can decrease ventricular filling and circulation. Tachycardia-induced cardiomyopathy. Prolonged rapid heart rate may damage and weaken the heart muscle. Hypotension or shock. Severe AF may reduce blood pressure and organ perfusion, and also increased mortality. Untreated atrial fibrillation is associated with increased risk of serious cardiovascular complications and even death. Anticoagulation is important in patients with atrial fibrillation because it increases the risk of blood clot formation and ischemic stroke. Anticoagulants can be initiated only after assessing the stroke risk and bleeding risk by using Chatz-Vasc score and Has-Blood score. Let's discuss about the Chatz-Vasc score first. So this is to assess the stroke risk in patients with atrial fibrillation. C stands for congestive heart failure, H for hypertension, A for age, D for diabetes mellitus, S for prior stroke or TIA or thromboembolism, V for vascular disease such as coronary artery disease, peripheral artery disease, and SC for sex category, especially female. So the scores will be given upon individual assessment of the patient, and if the N score is 0, that indicates low risk. No anticoagulation is required. If the N score is 1, which indicates low to moderate risk, so anticoagulation can be considered, all based upon the individual patient assessment. If the score is 2 or more, that indicates moderate to high risk of stroke, and here the anticoagulation is highly recommended and the maximum score is 9. Let's discuss about the Has-Blood score. This is mainly to assess 1 year risk of major bleeding in patients on anticoagulation or to consider anticoagulants. H stands for hypertension, A for abnormal renal or liver function, S stands for stroke, B for any history of bleeding, L stands for labile INRs, E elderly, age more than 65 years, and D stands for drugs or alcohol. So the maximum score is 9. The scoring will be given based on individual patient assessment. If the total score is between 0 to 1, that indicates low risk and it is safe to consider anticoagulant. If the score is 2, that indicates moderate risk. Anticoagulant can be considered but with caution and regular monitoring is necessary. If the score is more than 3, that indicates high risk of bleeding and consider alternatives to anticoagulation. As I said before, the anticoagulants can be considered only after assessing the stroke risk and bleeding risk by using Chads-Vas score and Has-Blood score. If the Chads-Vas score is high and the Has-Blood score is low, the patient can be initiated on anticoagulants. If both Chads-Vas score and Has-Blood score is high, can consider anticoagulants but with caution and always try to correct the risk factors. If the Chads-Vas score is low and the Has-Blood score is high, then may defer the anticoagulation because the stroke risk is low. Let's move on to the treatment option of atrial fibrillation. So whenever you are receiving the patient, first assess for hemodynamic stability. If the patient is unstable with hypotension, shock, acute heart failure, or ongoing ischemia, then generally requires urgent synchronized electrical cardioversion. Next is rate control. Control the ventricular rate to reduce symptoms. Common options include beta blockers, digoxin or diltiazem or verapamil when appropriate. The third one is rhythm control. Restore and maintain sinus rhythm using electrical or pharmacological cardioversion, antiarrhythmic drugs, or catheter ablation in suitable patients. Next comes the stroke prevention. Assess the thromboembolic risk and use oral anticoagulation when indicated. Direct oral anticoagulants are commonly preferred in eligible patients, so the treatment depends upon the patient's individual risk. Next is to treat the underlying causes or risk factors. Manage hypertension, diabetes, obesity, sleep apnea, heart failure, alcohol use, and other contributing conditions. Follow-up is mandatory. Regularly reassess symptoms, heart rate, rhythm, anticoagulation, risk factors, and response to treatment. Here comes the main responsibility of nurses to educate and empower the patient. So always educate the patient about medication adherence. Take rate or rhythm control medicines and anticoagulants exactly as prescribed. Do not stop them without medical advice. The second thing is self-monitoring. Teach patients to recognize symptoms and report changes promptly for cardiac reassessment. Lifestyle management, which includes controlling blood pressure, maintain a healthy weight, exercise as advised, stop smoking, and limit alcohol and excess caffeine. Educate them to recognize the warning signs and to seek urgent help for chest pain, severe breathlessness, fainting, or stroke symptoms such as facial drooping, arm weakness, or speech difficulty. Educate about the follow-up. They should attend regular appointments for ECG, medication review, and assessment of stroke and bleeding risk. Last is to empower the patients. Always encourage the patient to ask questions, participate in treatment decisions, recognize triggers, and maintain a healthy lifestyle. In conclusion, every episode is an opportunity. Each AF episode is a window to intervene before a devastating embolic event. Excellence is always defined by vigilance, precise risk stratification, vigilant monitoring, and patient-centered education define exceptional nursing care. So let's all master detection of the irregularly irregular pulse, a skill that transforms patient outcomes. Thank you so much for watching my video. I hope this would be helpful for you guys. If you feel the same, kindly subscribe. My channel name is Jebin Shine, and don't forget to press the bell icon button so that you will get the notifications whenever I am uploading new videos. See you all again with one more interesting topic. Until then, it's bye from Jebin. Bye bye. Take care.